Yeah, so I think, JAK inhibitors have been sort of our mainstay in myelofibrosis therapy for about a decade, a little over a decade now since ruxolitinib was approved. And so, obviously a little bit newer now with multiple agents coming out, but still, a lot of those drugs achieving sort of the same things. And so, many patients do benefit from JAK inhibitor use, but not necessarily all of them. We do see, a subset of patients who predominantly have anemia, or patients who are very lower risk disease and really don't have much in the way of symptoms who don't necessarily need a JAK inhibitor, at least sort of right in the frontline setting. And contrary to that, in patients who are higher risk and have significant spleen and symptoms, we do see benefit by using it early in the disease course. So it is important to these symptomatic patients and high-risk patients to try and use JAK inhibitors early on. When we're treating with these agents, generally patients do tend to feel better by shrinking spleens down and improving those symptoms, but certainly can see some toxicity. A couple of the agents we do see some GI toxicity with, and so it's important to sort of counsel on that and provide sort of supportive care in the first couple months until that typically does resolve. Also important, particularly in patients on ruxolitinib and fedratinib, where we can see quite a drop in hemoglobin and platelet counts, mostly in that first 2 to 3 months of therapy where we really see that occur. So it's important to sort of monitor blood counts very closely in the first couple months. And then generally once we see those sort of start to plateau, can start to space out how often we're seeing those patients again. There is some risk of infections and opportunistic infections, so that is something to sort of keep in mind in patients sort of when we're using these agents, as well as potentially an increased risk of non-melanoma skin cancers that are important to sort of keep an eye on in these patients as well. But generally once we're using it, especially with agent like ruxolitinib with sort of different doses, it's important to sort of optimize that dose to try and achieve effective doses and sort of titrate the dosing to response. Do have to be careful about blood counts and things like that, but certainly especially with ruxolitinib, we see a clear sort of dose response effect for spleen and symptom response. So important to try to get up to those optimal doses and maintain patients on dosing as long as they're sort of continuing to get some benefit from the drug. And now we do have some data with these newer agents of sort of second-line JAK inhibitor use as well, which is an important sort of aspect for these. A key sort of thing about when you're thinking about switching or stopping these is that certainly do not want to abruptly stop JAK inhibitor. You can see a pretty, sometimes very dramatic sort of withdrawal symptom, and patients actually get pretty sick from that sometimes. So it is important to, if you're stopping altogether, to sort of taper that off, generally over a few weeks. And really ideally what you want to do is really have a backup option sort of in mind that you're going to immediately transition them to. Often, another JAK inhibitor now, certainly clinical trial is an important option in this setting as well. But I generally do continue ruxolitinib with the thought that it's giving at least some benefit until I'm immediately starting on sort of that next line of therapy to avoid sort of acute worsening of the disease and some of the things that we can see when stopping a JAK inhibitor.